Current QAS drug therapy protocols state that the indication for fluid therapy in pediatrics is for hypovolemia and inadequate tissue perfusion or shock. Hypovolemia, inadequate tissue perfusion, and shock can present as a result of trauma or excessive blood loss. Research by Hussman et al. In 2012 has found that fluid replacement in pediatrics after trauma can impact on the coagulation system, hemoglobin concentration, and result in higher mortality rates. It has also been established that pediatrics have a higher requirement for packed red blood cells after fluid therapy. This particular study found that fluid therapy in pediatrics, particularly those with hemorrhagic shock, resulted in worse clinical outcomes and higher mortality rates. Another study by Teach and Toja, Lund and Fleischer in 1996 found that out of 50 patients, only 2 benefited from pre-hospital fluid therapy rather than spending less time on scene and rapid transport to hospital. Another study in 2013 by Maitland et al. Discovered that pre-hospital fluid therapy in pediatric shock patients increased the risk of cardiovascular collapse. These studies also discussed that giving small amounts of fluid slowly actually had beneficial qualities for pediatric patients. However, this brings up the argument of whether it is more important to give a pediatric patient fluids or whether to transport the patient rapidly. There are 3 conditions which are indications for sodium chloride, and these conditions can be deemed time critical. Therefore, is it really worth spending the time to give a pediatric patient fluids on scene or to pack and go and get them to hospital as soon as possible? The research in regards to pre-hospital IV fluids for pediatric is very conflicting, and there does not appear to be a clear consensus. What has been identified through our research is that fluid therapy in pediatrics results in longer time on scene. However, the clinical outcomes were no better, if not worse, because of the longer times on scene, as well as the results of the fluid replacement. There is significant evidence to suggest that in many situations, fluid therapy is not effective and can actually be detrimental to the patient. In 2008, Carr, Bratchett, David, D'Souza, and Branas found that on average, the process of gaining IV access increases the on-scene duration by at least 3 to 5 minutes. If IV access is only indicated by fluid therapy, then this would be unnecessary time spent on scene. This process of getting IV access specifically for fluid therapy opposes the traditional view and protocols of paramedics. This view was that the sooner you can get a patient to hospital, the better the patient's clinical outcome. In 2016, Brown et al. Demonstrated that increased time spent on scene compared to time to definitive care is associated with increased mortality. It is important to note that often the patient who requires IV access, such as severe trauma, shock, burns, and pediatric patients, can be challenging to cannulate due to their injuries and presentation. Ambulance services like QAS acknowledge this issue and have protocols in place which limit the number of attempts to gain IV access to 3 attempts unless it is justified to make further attempts. If a patient who needs fluids requires more than 1 attempt, the paramedics should use their clinical judgment as to whether it is time and cost effective to continue attempting overloading and going. In 1994, Bicknell et al. Showed that delaying fluid therapy rather than giving it immediately in particular types of trauma patients results in better clinical outcomes. Whilst Bicknell's results are applicable to a non-urban environment, it is arguable that this is not true in isolated locations. When transport time to definitive care is substantial, the benefits of immediate fluid therapy are increased. There are situations where there is merit to fluid therapy. However, our discussion is centered around the use of fluid therapy in the pre-hospital setting. It is our position that this is an intervention that should be shifting away from the pre-hospital environment and moving towards hospital use.
Created using Powtoon.